See, both HIV and HIV-2 are the zoonotic infections. So earlier it was thought that HIV was infected from the chimpanzees and the monkeys. And HIV-1 is very infective and HIV-2 is not that infective. And the viral load is also very high with HIV-1 and it is easily transmissible from the person to the person is the HIV-1. Both are transmitted through the same routes associated with the similar opportunistic infections, but HIV-1 is more common worldwide, whereas HIV-2 is found in some parts of the West Africa, Mozambique and Angola. 2 is less pathogenic. The duration of the HIV-2 infection is very shorter. And first case was detected in the US in 1981 in homosexual individuals. At the same time, several people were infected with this type of the disease, and no one knows that this is because of the new virus. So in 83, in the French population, so they discovered this virus as the lymphadenopathy associated virus. At the same time, in 84, in the US also, Gallo by others, they also detected the same virus there, and they named it as the human T lymphocytic virus 3, HTLV3. So in 1886, the international group was studied and they are given the one name to all these viruses which is causing this mysterious disease, especially in the homosexual individuals with a lot of the immunodeficiency, and they considered it as HIV. That is a human immunodeficiency virus. That is how the HIV name was given in 1986, even though the first case was detected in 81 in US. So the other names here, that human T-cell lymphotrophic virus from 81 to 86 in US, and lymphadenopathy associated virus in Europe, and AIDS associated retrovirus in other countries, and finally it is the HIV from 86 onwards. It is one of the largest epidemics of the 20th century. A lot of the people were infected with HIV, maybe because of the ignorance or maybe because of the lack of the understanding of this disease. And approximately a lot of the millions of the people living with HIV by the end of the 2007, there are about 40 million or 45 millions in 2019 or the 20 also. And a lot of the people are infected and they got the diseases, they got the opportunistic infections, they got the new malignancies like Kaposi sarcomas or lymphomas or cervical carcinomas, etc. And a lot of the people, they used to die much early, most prematurely they die because of this AIDS. So it's the negative economic impact on the countries, almost all the countries which are infected with HIV. So obviously the negative economic impact, because most of the people here are between the age group of between 20 and 40 years of the age group. So the most productive age group, they was infected with the HIV and then they got the AIDS and then finally they die much early. So overstrained healthcare systems. Life expectancy has decreased by 20 to 25 years and sometimes even the 30 years also. So earlier, a lot of the people, they used to die suicidal tendencies. So once they got posted positive for the HIV positivity, so even the doctors, I know a few doctors, maybe 6 to 7 of my known doctors, they died because of the positive of their HIV status. So now you see that it's a very silly thing, because all the people are living very happily, even though with HIV positivity, because of your heart therapy. So highly effective antiretroviral therapy. So most of the people, they are not dying early. Almost all the opportunistic infections have reduced in its incidence. Almost no one is getting the malignancies. Now the HIV is almost like a chronic disease. Just like your diabetes or hypertension or IHD or the CKD. Now the HIV is no more a killer. But earlier, before the introduction of these new molecules, so definitely there was a decrease in life expectancy and reversal of the child surviving gains, increase in number of the orphans, because both the parents, they were infected with HIV and then they died. The children, they became the orphans. HIV prevalence is very high in South India, especially the Andhra Pradesh, Telangana, Tamil Nadu, Karnataka and Maharashtra. It's a high prevalence states, and also in the northeast like Manipur and Nagaland. Here in India, about 85 to 87% is the heterosexual. Men who have the sex with the men, this is a very popular and a very dangerous group. There are about the 2%. So they are getting more and more opportunistic infections. Even the malignancy is also more common in these individuals. And injectable, the drug users, drug addicts, they are about the 2%. And parent to the child is about the 5%. Now, luckily, we are giving the nevirapine and other retroviral drugs. And now the parent to the child has transmission has stopped very high in numbers nowadays, but earlier it was a 5%. Blood products, that is about 1%. And even today, unknown methods, maybe not because of their heterosexuality or the homosexuality or the drug abuse or the blood products or the parent to the children, still 3% unknown routes of getting the HIV and the AIDS in the Indian population. Even though the first case was detected in the US in 86 in India, in Chennai, the first case was detected, and later lot of the developments have occurred in India, and now we are very safe that the incidence of the HIV has reduced very drastically, and also lot of the NGOs are coming forward, and then they are providing the free drugs to all the HIV positive individuals, and also they are getting they are checking the viral load, they are checking the CD4 count without any cost. So that's how the life of the HIV positivity or the AIDS individuals in India is they are doing well. This is the 2017 status, and if you see the new HIV infections in 1.2 lakhs in 2010, they have reduced to the 88,000 in 2017. And AIDS related deaths, HIV is different from the AIDS. AIDS means once the CD4 count is less than the 200 or 300 or 400, then they got the infections. Lot of the infections like respiratory or the cardiovascular or gastrointestinal, etc. with very low CD4 count and very high viral load. Then we consider this person as an HIV AIDS, that is acquired immunodeficiency syndrome. So 1.6 lakhs for 2010, they have reduced to the nearly 70,000 in 2017. Now the people living with HIV is drastically reducing. So 2010 it about 23 lakhs. Now it is at 21 lakhs. But sometimes I don't believe these numbers. But they may be the underreported also, because most of the people, they get tested in the private labs or in the nursing homes or in the corporate hospitals. So they may not be included in our national figures. So here in the 2017, 2.1 million people living with HIV in India, and 0.2% adult HIV prevalence, but overall the world prevalence is about 0.8%. And even today, 80% of the HIV positive people, they are living in Africa. So Africa is having the high load of the HIV positivity in the world. In India, about 88,000 new HIV infections in 2017, 69,000 AIDS related deaths, 56% errors on the antiretroviral therapy. That's a good move. So earlier there are only 5 to 10% of the people they used to get the heart. Now nearly 60% of the people they are getting the antiretroviral therapy. See, 79% aware of their HIV status, of which 71% on HIV treatment, of which virtually suppressed, not available the exact figures. But nowadays, whenever they are going to the ART centers, they are getting the CD4 count and the viral load also. So the key points in the HIV medicine, it's a global pandemic, and the number of people living with HIV continues to increase worldwide. HIV epidemic is especially severe in the resource constrained settings like in Africa. HIV is a virus that destroys the immune system, leading to the opportunistic infections. The progression from initial infection with HIV to the end stage AIDS varies from the person to person and can take more than the 10 years. Some people are even the 20 years, 30 years. So I have seen one few people who are positive in 90s or in the 2000s, they are still not having any AIDS because their CD4 count is always higher, their viral load is not detectable, and they are almost behaving like a normal person. So that is a possible. But usually they will take a longer period, minimum 10 years or 15 years, 20 years from HIV positivity to become AIDS related diseases. The most common main route of transmission worldwide is the heterosexual transmission. Women of childbearing age are at particular risk for acquiring the HIV through unprotected sex. HIV positive women who are pregnant are at risk of passing HIV infection to their newborn. Risk of HIV transmission from mother to the child can greatly reduce the effective programs. So these are all what you mean by PMTCT. So whatever the demographic impact of the HIV and the AIDS, in the worst affected countries, HIV has reduced the life expectancy by over 20 years. In Southern Africa, life expectancy has dropped below the 50 years. In the worst affected countries, HIV causes over 1/3 of the child deaths. In the 7 countries hardest hit by the HIV, under 5 mortality has increased by 36%. Okay. So H infects only the human beings. High, it is the immunodeficiency virus, weakens the immune system and increases the risk of the infections and the malignancies. V, virus that attacks the body. So only humans, immunodeficiency, it's a virus. AIDS, it's not inherited, it's an acquired one. So I stands for weakness of the immune system. Creates a deficiency of CD4 cells in the immune system. So the CD4 cell count will be reduced. And it's a syndrome, it is not a disease, a group of illnesses that take place at the same time. So that is the AIDS. Okay. So in AIDS, most of the people will be having the respiratory complications, and they have the gut complications, then they have the neurological cryptococcus or toxoplasmosis or tuberculosis, etc. See, weight loss of more than 10% of the body weight, diarrhea lasting longer than the 1 month, and fever lasting longer than the 1 month. So they undoubtedly it could be a case of the AIDS. So earlier, a decade or 2 decades earlier, whenever a fellow comes with these 3 things, with a fever more than 1 month, or the loose motions, continuous loose motion more than the 1 month, or weight loss more than the 10%, so undoubtedly get it checked for the HIV positivity. And most of the time they were the positive. What are the effects of the virus? That attacks the white cells that fight infection in the healthy population, changes the composition of the white WBC and enables the HIV to replicate itself. So the more and more HIV replication will be there, and obviously it weakens the immune system and increases the vulnerability to the life-threatening illnesses, like what are all the infections I told you. So that causes. So that maybe causes the viral myocarditis, maybe the pericarditis, maybe the gastrointestinal, gastroenteritis, etc. So definitely lead to the life-threatening complications. The physical factors affecting the transmission and the vulnerability of the viral strain of the HIV virus, viral load. So the more the viral load, so obviously more the immune defects. And strain of the HIV, so mostly the type 1 is more virulent and more pathogenic. And the host, presence of the sexually transmitted infections. So again, a big risk factor to get infected with the HIV. And stage of the infection. So circumcision, that reduces the incidence. And hereditary resistance to the HIV is very, very rare. But some people who have the resistance to the HIV, so they're the lucky people not to get infected with the HIV. There are some social factors, the views towards the women, youth perceptions of the sex and risky behavior, high risk individuals, especially the youth. That is the main reason to cause the HIV in a rampant manner. So definitely the risky behavior should not be there, especially in the youth individuals. So definitely they should be aware of all these things. Mobile and the vulnerable populations influencing the frequency of the sex partner changes, especially the lorry workers, highway travelers. So they are the more population influence. Usually they are more prone for this HIV, especially the jailers, inmates of the jail, inmates of the last hostels, and then the army. So these are the people who are vulnerable and who are more susceptible to get infected with the HIV. Established presence of the HIV in the community. So always, most of the communities there's an established presence is there. And phases of the infection, HIV infection could be acute, it could be asymptomatic, symptomatic, and the late symptomatic or the full-blown AIDS. So the acute HIV infection, it's almost like your any viral infections like fever, myalgia, body aches, headache, etc. Asymptomatic, so after some time, again the people will be the asymptomatic, even though they are having the HIV positivity, people living with HIV. So they are asymptomatic for many years, maybe 5 years, 10 years, 12 years, until they get the symptomatic. So once the CD4 count is coming down, once the viral load is increasing, so they become the symptomatic. So then the onset of the opportunistic infections and the further increase in the nutritional requirements. And finally, there will be the full-blown AIDS. So more viral load, intense weight loss, wasting, etc. and opportunistic infections taking control. And they will be having more and more infections. So a combination of your gastroenteritis, combination of your tuberculosis, and then the cryptococcus, and then the toxoplasmosis, and then the convulsions, encephalopathies, thrombocytopenias, hemolytic anemias. So you name any system in the body, so that will be infected with AIDS, involved in the AIDS. It may be negative during the first 3 months after the infection, that is called as the window period. So even though you get the antibodies are negative at this juncture, so the only way to get it positive is your PCR only or NAT test. 2 tests are required plus a third to confirm if the results are conflicting. So we get the 2 tests in the different kits. Then the two are positive. So definitely this patient is a HIV positive. You may not go for the Western blot. Repeated test recommended the 3 months after the initial test, and false positives are very possible in the children under 18 months of the world. So false positives, even in the some people who are the chronic alcoholics or the chronic smokers, whose immunity is not that good, so definitely there may be the false positives also. So high index of suspicion must be there, and even though the first result is the negative, and you get it tested done with another kit, another company's kit. So otherwise you can go it for the NAT or the RT-PCR, etc. Blood test for the antibodies against the HIV is the most common, is the ELISA. So the enzyme immunoassay or enzyme linked immunosorbent assay, and gold standard is the Western blot, more specific than the ELISA and used as a confirmatory test. So Western blot is the most important test and is the most confirmatory. And radioimmunoassay, expensive, used as a confirmatory test when antibodies are the very low. Dot blot immunobinding assay is a cost-effective rapid screening test. And PCR, it measures the HIV genetic information. Even in the window period also you can get it tested. The people will be positive. And not only the blood, sometimes all these things can be done with the urine also, and also sometimes the oral fluid tests. So urine test for the antibodies in the urine, not as sensitive as the blood. Enzyme immunoassay or Western blot, that can be positive even with the urine also. Test for the antibodies on the oral fluids, not the saliva here, it is the oral. Again, the enzyme immunoassays and Western blots can be done with the oral fluids. But usually 99.9% will get it tested with the blood only. HIV virus invades the helper T cells and the CD4 cells in the body of the host. So the defense mechanism of the person is threatening a global epidemic, is preventable and manageable, but is not curable. So it's like a chronic disease. It is not curable, but it is definitely a manageable one right now, and 100% is a preventable one. So can prevent the prevention from your heterosexual or from the homosexual activity or your high risk behavior, etc. It is the final stage of the HIV AIDS, which causes the severe damage to the immune system. It is the virus that causes the AIDS. Disease limits the body's ability to fight the infection due to the markedly reduced helper T cells, that is CD4 cells. Patients have a very weak immune system, so the defense mechanism is very weak here. They are predisposed to the multiple opportunistic infections and left untreated, so definitely a death is guaranteed here. AIDS predisposes our body to other opportunistic infections. These opportunistic infections and the malignancies that rarely occur in the absence of the severe immunodeficiency, but they are very common in the presence of the immunodeficiency like HIV. Persons with positive HIV serology who have ever had a CD4 count below 200 or a CD4 lymphocyte percentage below 14% are considered to have the AIDS. So to consider the person as an AIDS, you can see these two things. One is the 200 cell count less than the 200 CD4 count, or the CD4 lymphocyte percentage below 14%. Then we consider them as the person is in AIDS. Transmission of the HIV is not transmitted by cough or sneeze or insect bites, touching, hugging, water, food, kissing, public baths, handshakes, work or school contact, using telephones, sharing cups, glasses, plates, and other utensils. So these are not the roots of transmission. So the only transmission is your heterosexuality, or homosexuality, or the blood products, or the needles, etc. So this is the viral genome. It's a 20-sided icosahedral enveloped virus. It's the enveloped virus. Lentivirus subfamily is the retrovirus. So retroviruses transcribe the RNA to the DNA. So actually it is the double-stranded RNA. Then after entering into our human body, this RNA will be converted to the DNA, and then it get infected very high. So the two viral strands of the RNA, in the inside you can see the S and S. They are the two standards RNAs surrounded by a protein outer coat. So outer envelope contains the lipid matrix within which the specific viral glycoproteins are embedded. These knob-like structures responsible for binding to the target cells. So the blood products, semen, vaginal fluids, so they are all transmissible. So the blades and then the needles. So either oral intercourse or the anal intercourse, they are very popular, especially in the homosexuals. Mother to the baby before birth or the during birth. And sexual transmission HIV has been demonstrated in the seminal fluid, concentrate in the seminal fluid in the urethritis and the epididymitis, cervical smears and the vaginal fluid. Male to female transmission is usually more efficient than the female to the male transmission. So I know some people, the males are the positives, whereas the female is the negative. The same way the wife is positive, but the husband is the negative, even though they are on regular love. So sometimes we don't know what could be the reasons for this, but definitely such people are also there in the society. The presence of the other sexually transmitted diseases, there are high chances of getting the HIV, and level of the plasma viremia is also there, and male circumcision is the lower risk of the HIV infection. Blood and blood products, injections the drug used does not require the IV puncture, maybe the subcutaneous or the IM. They can also transmit the infection, not always the IV. Maybe IM and subcutaneous also can transmit the virus. 90 to 100% they become infected with the blood spread. Unsafe whole blood, packed red cells, platelets, leukocytes, and the plasma. So one should be very careful in handling these things. Unsafe is the globulin, immunoglobulins, plasma-derived hepatitis B vaccines. The screening of all blood for HIV nucleic acid, P24 antigen and our anti-HIV bodies. But usually in our labs, in our blood banks, they do only the antibodies. So even though the fellow is in the window period, so definitely if you don't get the RT-PCR and you are going to miss that blood is having the HIV positivity. Occupational transmission, the skin puncture from a needle or a sharp object is about 0.3%. Now the more and more tattoos, they are dangerous. Mucous membrane, 0.09%. Transmission through the intact skin, not documented. Infectious fluids like the blood and visibly blood clotting, semen and the vaginal secretion, cerebrospinal fluids, synovial fluids, pleural fluids, peritoneal fluid, pericardial fluid, amniotic fluid. So all these fluids, they are rich with the virus. Maternal to the fetal and the infant transmission, that during the pregnancy, during the delivery, or by the breastfeeding. So by these three means, the mother can transmit the disease to the fetus. HIV can be transmitted to the fetus as early as the first and second trimester of the pregnancy. So occurs most commonly in the perinatal period. Presence of the high maternal levels of the plasma viremia, low maternal CD4 T cell counts. So mother CD4 count is 200 or 250 or 300. So there are high chances of getting transmitted to the fetus. Prolonged interval between the membrane rupture and the delivery. Presence of the chorioamnionitis at the delivery and STDs during the pregnancy, smoking, preterm delivery, obstetrical procedures such as the amniocentesis, etc. So there are high chances of getting the infected. So maternal fetal transmission. See the obstetric management, avoidance of the breastfeeding, highest in the early months of the breastfeeding. Nevirapine, a single dose given to the mother at the onset of the labor and a single dose to the infant within 72 hours of the birth. So they definitely very prophylactic drugs. They can reduce the transmission of this virus to the infants. What are the cellular activation and the HIV pathogenesis? See, as you all know that this is the reduced immune functions. So the aberrant immune activation by hypergamma-globulinemia, spontaneous lymphocyte proliferation, activation of the monocytes, expression of activation markers on CD4 and CD8 cells, increased activation associated cellular apoptosis, lymph node hyperplasia, increased secretion of pro-inflammatory cytokines, elevated levels of the neopterin, B2 microglobulin, interferon, and soluble interleukin 2 receptors. See, these are all the apparent immune activations, so which is very, very common with our HIV positivity individuals. If you see here, the globulins will be deranged, the monocytes, the lymphocytes, CD4 cells, CD8 cells, and also there will be the pro-inflammatory cytokines, and then the interleukins, microglobulins. So these are all, there will be the alteration in these things. So just by these alterations, so definitely the immune function will reduce. Endogenous factors like the cytokines and exogenous factors like the viruses, mycoplasma, nematodes, malaria, tuberculosis in a country like India. So these are all very, very common. So not only on one side your HIV positivity, but on the other hand, so you have these infections also like the tuberculosis, malaria, and etc. What is the immune response to the HIV? So the immune response, there will be the humoral immunity, a complement immunity, cell-mediated immunity. So all these things will be involved here. Among the humoral immunity, there will be the binding antibodies, neutralizing antibodies, the tri-specific or the group-specific, antibodies participating in the ADCC, the protective or pathogenic, enhancing antibodies. So these are the defects in the humoral immunity. And then the complement systems, your C3 and the C4 levels. And the cell-mediated immunity, you have the helper CD4 T lymphocytes will be reduced. And then other cytotoxic CD8 T lymphocytes. Then the non-cytolytic CD4-8 cells. Then natural killer cells. So if you see the immune system, and almost all the things in the immune system will be deranged in the presence of the HIV positivity. Now the pathogenesis and pathophysiology. See, if you see here, so these are all the cellular DNA. So I told you now the RNA earlier. Now the RNA will become the DNA here. So there will be the integrase, so genomic RNAs, then there's some co-receptors and the protein synthesis, budding, fusions. So these are all the different things happens inside the cell in the HIV positivity. So the finally the mature HIV virion also will be there, and that they get infected to the other cells. See here the two things are important. One is the viral load and the second one is your CD4 count. See, if you see the viral load, so earlier the viral load will be very good, more than the 10,000s, more than the thousands, etc. And slowly the count will come down to almost to the negligible things, maybe in the single digits, and then finally death will come. And what happens to your viral load? See, the acute HIV infection syndromes, wide dissemination of the virus eating up the lymphoid organs. So then the viral load will be very, very high. And later there will be the inertia and the load will come down to some extent. And that will stay for about 5 years, 10 years, 15 years, depends on the body's immunity. And slowly again the CD4 count will go up. So first they will have some constitutional symptoms. Then they will have the opportunistic infections. Once the viral load is very high. And then finally more and more opportunistic diseases and the neoplasms and the death. So by the time the person is died of this HIV positive and AIDS, So the viral load will be very high, and whereas your CD4 count is very, very, very low. The primary HIV infection, initial viremia, and the dissemination of the virus. So first is the gut-associated lymphoid tissue. Then the dendritic cells, that is disease sign, and dissemination of the virus to the brain and the other tissues. See here the primary infection. Then the second point is your gut involvement, the establishment of the infection. Then there will be the massive viremia and wide dissemination to your lymphoid organs slowly. Then the trapping of the virus and the establishment of the chronic and the persistent infection inside. Here they stay for longer years there. Then slowly the immune system will get mediated by the cytokines and HIV envelope mediated aberrant cell signaling and accelerated virus replication, and finally the destruction of the immune system, then appearance of your opportunistic infections and the neoplasms, and finally the death. So this is how the system will go on. So the gut is very important, the immune system is very important, and the finally opportunistic infections and the neoplasms are very important here. Establishment of the chronic and the persistent infection. Here the persistent virus replication, evasion of the immune system control, and reservoirs of the HIV infected cells. The same thing here, the resetting the CD4 T cells, T cell activation, that is the cytokines, then cytopathic effects of the virus, viral spread, viral replication, and then the T cell activation, post integration. So there are the different mechanisms that occur in your CD4 count, and finally the virus spreads like anything. Almost all the organs and the tissues in the body will be infected with this HIV. There are the two groups of the peoples who are long-term survivors and long-term non-progressors. Long-term survivors, they remain alive for 20 years after the initial infection, may have the significant immunodeficiency, may have experienced the opportunistic diseases. They are the long-term survivors. Long-term non-progressors, infected with HIV for a long period, CD4 T cell counts were in the normal range and remained stable over the years, had not received the ART therapy. Even they have not received the ART therapy, the CD4 counts will maintain the normal things. So they are the non-progressors. They have the low levels of the plasma viremia. So at any time you get the test viral load is very unremarkable. Normal immune functions, your skin tests, in vitro lymphocyte responses, etc. And lymph node biopsy is also the normal. So they are the lucky population, lucky people are the long-term non-progressors. Even though the virus is there, the CD count will not reduce and viral load will not increase, and they will have a near normal life. So this is the primary infection in 3 to 6 weeks, acute syndrome. And this acute syndrome, again there will be the immune response to the HIV, and then there will be the plasma viremia or establishment of the chronic disease, and finally there will be the clinical latency. So let us see the natural course of the AIDS. So stage 1 is a short flu-like illnesses, occurs 1 to 6 weeks after the infection. Mild symptoms. Most of the people, they may be asymptomatic also. Infected persons can infect the other people at this juncture. And these are all the main symptoms of the acute HIV infection, like fever, weight loss, pharyngitis, oral ulcers, esophagitis, myalgias, maybe hepatosplenomegaly, malaise, headache, some neuropathies, lymph nodes, especially cervical lymphadenopathy or axial lymphadenopathy, some rash, nausea and vomitings. So these are all the acute symptoms of the HIV syndromes, acute HIV syndromes. See, this is the here. The fever, chills, headaches, night sweats, sore throat, myalgias, arthralgias, fatigue, lymphadenopathy, and abscess ulcers or mouth ulcers. So the many patients experience no symptoms also. So asymptomatic majority of the individuals, even though they are symptomatic, these are the acute HIV infection. But it almost looks like any viral fever. Any viral fever can have all these things. So once they know that it is an HIV positivity, how to cope up with an HIV diagnosis. So see a therapist Find a doctor with whom you feel comfortable. Join a support group. Educate yourself. Remember, you can still have a long and healthy life. So happy birthday, 80 years, 90 years, 100 years is possible. So provided if you have a good CD4 count and a good viral load, very negligible viral load, and then no opportunistic infections, no malignancies. So even the HIV positive individuals can see their 80th or 90th or 100th birthday like any other person. Stage 2 is asymptomatic. The lasts for an average of the 10 years. This stage is free from the symptoms, is asymptomatic at this juncture, but the virus is there. They keep on attacking the CD4 counts and slowly increasing their number. There will be the swollen glands. The level of HIV in the blood drops to the low levels. HIV antibodies are detectable in the blood. So they are the most vulnerable and the dangerous people. They are asymptomatic, but they are potent. Transmits the disease to the other persons. Asymptomatic stage, clinical latency, a median time for untreated patients 10 years. HIV disease with the active viral replication is ongoing and the progressive. Directly correlated with HIV RNA levels. The average rate of CD4 T cell decline is 50 per liter per year. So the long-term non-progressors and elite non-progressors. And after 5 years or 10 years or 15 years, so again they become the symptomatic because of the opportunistic infections now. Here the immune system deteriorates, opportunistic infections and cancer start to appear and they become the symptomatic. So once they have the opportunistic infection of the gut, they will have the GIT symptoms. If they have the pneumonias or pneumocystis carinii, etc., or tuberculosis, they will have the respiratory symptoms. Immune system weakens too much as CD4 cells decrease in the number. So they will have these rashes, furuncles, paniculitis, etc. So when the count is less than the 500, so there will be the bacterial infections, tuberculosis, herpes simplex, herpes zoster. These are very, very common. Vaginal candidiasis, hairy leukoplakia, Kaposi sarcoma. So these are all very common when the CD4 count is less than 500. When the count is less than 200, then the pneumocystis carinii, toxoplasmosis, cryptococcosis, meningitis, coccidiomycosis, cryptosporiosis, non-Hodgkin's lymphoma, Burkitt's lymphoma, etc. So these are all common with CD4 count less than 200. When the count is less than 500, so before they are going to die, disseminated Mycobacterium avium complex infection, histoplasmosis, retinitis, CNS lymphomas, progressive multifocal leukoencephalopathy. So all the white matter derangements will be there. So there will be the dementia, there will be the Alzheimer's, there will be ataxia, lack of concentration, restlessness, ataxia. So they are all very common with the progressive multifocal leukoencephalopathy. And then HIV dementia. See opportunistic infections, HIV infected individuals CD4 less than 200, pneumocystis girovesi or pneumocystis carinii prophylaxis. So give with your cotramaxazole. For HIV infected individuals CD4 less than 75 cells. So give the prophylaxis for your Mycobacterium avium complex with your INH. For HIV infected individuals CD4 less than 50 cells. So cytomegalovirus prophylaxis. Okay, maybe again the cotramaxazole or your albendazole, etc. So here these people are divided into 3 groups, A, B and C. A is asymptomatic and acute primary HIV. B is symptomatic, neither A or C. C is AIDS. So here the count more than the 500. So level 1, A1, B1 or C1. When your CD4 count is between 200 to 500, then the A2, B2 or C2. When the count is less than 200, then the A3, B3 and the C3. So depending on the count, depending on the person in the early stages or in the late stages, So ABC. So the A category. One or more of the conditions listed below with a documented HIV infection. All are HIV positive here. Conditions listed in the category B and C must not have occurred. Asymptomatic, persistent generalized lymphadenopathy, or acute HIV infection with accompanying illness or history of acute HIV infection. So they are the category A individuals. So the B is a very big group. They are all the symptomatic conditions. So examples, constitutional symptoms as fever, diarrhea, etc. more than the 1 month. Candidiasis, oropharyngeal, vulvovaginal candidiasis, hairy leukoplakia, herpes zoster, ITP, peripheral neuropathy, PID, pelvic inflammatory diseases. So these are all very, very common in category B. In category C, established AIDS patients. So candidiasis of not only your oral cavity or the external genitalia, here the candidates of the bronchi, candidates of the trachea or the lungs, esophagus. So the chronic ulcer herpes simplex more than 1 month's duration. Cervical cancer, invasive cervical cancers. It is very common in our Indian population. Your pneumocystis carinum is not that common in India, but the non-Hodgkin's lymphoma and invasive cervical cancer is very common in our Indian population with AIDS. Cryptococcosis is extrapulmonary, cryptosporiosis, histoplasmosis, isosporiasis. So these are the very common opportunistic infections one can see in AIDS. So all these things, pneumocystis, pneumonia, recurrent pneumonias, extrapulmonary MAC or cancery, Mycobacterium tuberculosis, any site, whether the pulmonary or extrapulmonary, maybe pericardial effusions, tuberculous pericardial effusions, or tuberculous meningitis, or Cox spine, so TB spine, or osteomyelitis, tuberculous osteomyelitis, or retroperitoneal lymphadenopathy, okay, or psoas abscess because of the Cox. So these are all very, very common sites in HIV positive individuals. Not only the lungs involvement may be 50%, and the rest of the cases you will have the involvement in other areas, in other organs. HIV related encephalopathy is a very common. Lymphomas, especially the brain, Burkitt's lymphomas, Kaposi sarcomas, and wasting syndrome. So no other symptoms except the weight loss. So the weight loss more than the 10 kgs, 15 kgs, 20 kgs. So definitely get it tested for the HIV positivity and CD4 count and viral load. So this I already told you the numbers down. Approach to the opportunistic infections. Degree of the immunodeficiency. A prophylactic treatment is very, very important here. Exposure to the potential pathogens and clinical syndromes, either the pulmonary, gastrointestinal, neurological, etc. Pulmonary complications, you have the acute bronchitis and the sinusitis, especially the maxillary sinusitis. Pneumocystis pneumonia, other bacterial pneumonias like your staphylococcus, streptococcus, pneumococcus, H. influenza, pseudomonas, proteus, etc. Tuberculosis in many ways, fungal infections, non-specific interstitial pneumonitis, Kaposi sarcoma, lymphoma. So these are all involvement of the diseases which are very common in the lungs. So any patches are in the lungs, it's not all tuberculosis in HIV positivity. So other than the tuberculosis, you should also think of these things. Maybe could be pneumocystis carinum, pneumonia, or maybe other causes of the bacterial pneumonias. Maybe the fungal pneumonia is a very common in tuberculosis. So unless you have that tissue diagnosis, the treatment is very, very difficult, and the person is going to die, provided if you treat all the diseases like the tuberculosis only or with ATT. See the picture here. So the bilateral, infiltrative. See here, the cup-shaped cysts, the pneumocystis, pneumonias. When the CD4 count is less than the 200, symptoms dry cough, dyspnea, fever, subacute onset, just like your tuberculosis or any other pneumonias. X-ray interstitial infiltrates, ground glass appearances. Even the normal X-ray is also possible in 10% of the cases. So that is the reason. Don't depend on only on the X-ray only. So if you have an index of suspicion, get the CT chest also. So to know the peripheral involvement or the central involvement, upper lobes involvement, or lower lobes involvement, or hilar adenopathies, etc. can be seen very extensively in your CT chest. Mild to moderate diseases, your trimethoprim sulfamethoxazole combination, dapsone, primaquine, clindamycin. So these are all the different drugs can be used in mild to moderate diseases of your pneumocystis pneumonia. Whereas in the severe diseases, so you can go up to the 21 days of your trimethoprim sulfamethoxazole combination. See here the simple pneumonia on the left upper lobe. HIV infected persons at increased risk. Pneumonia 20 times, bacteremia 50 to 100 times. Risk is great when the CD4 count is less than the 200. Here the pneumonia is depending on the organisms. If it is a gram positive, maybe the penicillin. If it is a gram negative, maybe the aminoglycosides. If it is a pseudomonas, maybe the linezolid. So etc. Depending on your cultural sensitivity, so you can use these drugs. Prophylactic, so use the heart, highly effective antiretroviral therapy, trimethoprim sulfamethoxazole, and vaccines, especially the influenza vaccine, pneumococcal vaccine, hepatitis B vaccine, herpes vaccine. So these are very important vaccinations to be done in all the HIV individuals not to have these diseases once their CD4 count is coming down. So in the asymptomatic phase itself, all the HIV individuals should get the vaccinated against all these opportunistic infections. See here the tuberculosis, serous tuberculosis, tuberculous meningitis, or disseminated tuberculosis depending on their CD4 count. So the pulmonary tuberculosis, when the CD4 count is 500 or 400, 450, 500, etc. Once it is coming down between 400 to 300, maybe the serous tuberculosis like your pericarditis or your pleural effusions or your TB abdomen. And TB meningitis when the count is less than 200. When it is less than the 100, a disseminated tuberculosis or miliary tuberculosis. So these are all very common. TB is the most common opportunistic infection in HIV, especially in India, and the first cause of mortality in the HIV infected individuals. 10 million patients co-infected in the world. Immunosuppression induced by the HIV modifies the clinical presentation of the tuberculosis. So mostly now we think that it is upper lobes involved in the tuberculosis, whereas in HIV individuals, it is the lower lobes that is very common involved, especially in the elderly individuals or uncontrolled diabetes or HIV positivity, you will have the lower lobe involvement. Okay. See here in the left upper lobe, you will have a cavity formation. So the typical pulmonary tuberculosis, cavitary pulmonary tuberculosis. See in the early HIV positivity, the upper lobe is involved here, the right upper lobe. Whereas in the late HIV, both the lower lobes are involved with the tuberculosis, severely immunocompromised. So maybe because of their aspiration pneumonias. So cough more than the 3 weeks, get the AFB done for the 3 days. Even the single day positive, so you can go for the ATT, and you have to wait for the second day and third day also to the positive to get it done. First day negative, second day positive. Okay, again go for the ATT. Or the first day, second day negative, third day positive, you can go for the ATT. Here the duration of the treatment is not the 6 months, usually 9 to 12 months we give it in HIV positivity individuals. And rifampicin is contraindicated with the protease inhibitors or non-nucleoside reverse transcriptase inhibitors containing hot regimens. Here the defer ART until the TB treatment is completed. So first give the tuberculosis treatment. So just wait for your ART. ART for wait. So that is a defer ART until the TB treatment is completed. Defer ART until the continuation phase of the treatment for TB and use HE, that is our INH and ethambutol as the continuation. Treat TB with rifampicin containing the regimens and use efavirenz and two non-nucleoside reverse transcriptase inhibitors. Okay. Here you can use the efavirenz in the presence of the tuberculosis to use the rifampicin. Otherwise, rifampicin is contraindicated with nevirapine. High TB HIV burden in Asia and the Pacific 2020. 68% of the estimated new TB cases globally, they are in the Asia and the Pacific region. So the pulmonary tuberculosis or tuberculosis of any nature, very, very common in our Indian countries. 19% of the estimated TB HIV co-infections globally. 57% of the estimated TB mortality globally. Over a third of the high TB burden countries are in the Asia and the Pacific. See again, the India is there. See the first one, left side, India. So third of the high TB burden countries are in Asia and the Pacific. Need to scale up the HIV testing among the TB patients in the Asia. Here again in the Asia. Scale up the HIV testing among the TB patients in Asia. All the TB patients in Asia should get the tested for the HIV positivity because of their close association with HIV positivity. A lot of the missed opportunities coexist. 2 in 3 people co-infect the TB HIV, they do not know their HIV status. So they are happy with the TB diagnosis only. But at least 2 in 3 people are missing the HIV positivity along with it. And 1 in 3 ART service providers, they do not provide the TB treatment in ART setting. They are giving just ART, not the TB treatments. 3 in 4 TB service providers, they are giving the ATT but not the ART. In 1 in 4 countries in Asia Pacific have the TB preventive treatments recommended in the national policies and guidelines for people living with the HIV. So what is the take home message is all the tuberculosis patients, especially the pulmonary tuberculosis or the extrapulmonary tuberculosis, should be ruled out the HIV positive. So 9 countries account for the 94% of all TB related deaths among the people living with HIV in Asia and the Pacific. See the India, strong one, first one, 38%. All 12 high TB burden countries in Asia and the Pacific have the high MDR tuberculosis. So multi-drug resistant tuberculosis. India is there. Fourth one is the India. High TB burden, right? High MDR TB burden. So multi-drug resistant tuberculosis. That is also very high in Indian population. So the take-home message is TB and HIV is a very, very common combination. And defer the ART till the ATT is over. And if you want to give the rifampicin, so avoid the nevirapine and use the efavirenz related combination drugs. And always give the 3 drugs, ARTs, 1 efavirenz and plus 2 NRTIs. This is the Mycobacterium avium complex, the clinical features: fever with highest stress, abdominal pain, diarrhea, weight loss, gross wasting, lymphadenopathy, or hepatosplenomegaly, and the treatment is the lifelong. Here the clarithromycin, ethambutol, drafabutil. Fungal infections are also very, very common in the HIV positivity and the AIDS. So the cryptococcal disease. Here the fever, cough, dyspnea, hemoptysis. Just looks like your tuberculosis, but it is not tuberculosis, it is fungal. Chest X-ray, focal or the diffuse interstitial infiltrates, Lowry disease, cavitary disease, some pleural effusion, hilar or mediastinal lymphadenopathy. So they are the typical findings in cryptococcal diseases. 50% fungamic, 90% have concomitant CNS infections. Coccidiosis immitis, the reactivation pulmonary syndrome in patients CD4 count less than 250. They have the fever, weight loss, and the cough. Chest X-ray extensive, diffuse reticulonodular infiltrates, nodules, cavities, pleural effusions, and hilar adenopathy. Aspergillus, pseudomembranous tracheobronchitis, not an AIDS defining the illness. Neutropenia or administration of the glucocorticoids. Histoplasmosis. See, these are all the some fungal infections which are very, very common in HIV positive and AIDS populations. So the histoplasmosis, aspergillus, coccidiosis, and cryptococcal disease. See, cardiovascular system will be involved in all the three layers in AIDS. So the outer one is the pericardium. Pericarditis and pericardial effusions are very common in HIV, mostly the tuberculosis. And myocardium involvement. So there is a cardiomyopathies or myocardial infarctions. So they are also very common in HIV individuals. And then the endocarditis. So endocarditis is also very common in AIDS individuals because of a lot of vegetations. So the direct consequence of the HIV infection, the consequence of the ARV therapy, especially the interferons and the nucleoside analogs, part of the lipodystrophy syndrome, associated cardiomyopathies, especially the dilated cardiomyopathies, late complication of the HIV infection. Here the treatment is immunoglobulins. Cardiomyopathy in the form of Kaposi sarcoma, cryptococcosis, Chagas and toxoplasmosis. And pericardial effusion, pericarditis, mostly the tuberculosis. So this is the oral candidiasis. See the oral candidiasis. So thrush, sore throat, pseudomembranous, atrophic, hyperplastic, angular cheilitis. Here the treatment is antifungals, your nystatin, fluconazole, etc. See the aphthous ulcers. Okay, hairy leukoplakia. So hairy leukoplakia is very common in HIV individuals. So adenophagia. So opportunistic infections are the tumors. Here the common the Candida species. Less common cytomegalovirus, simplex virus. Rare tuberculosis, aristoplasmosis. GERD is very common here. So I have to use these drugs. So the oroesophageal candidiasis. Here you have to use the fluconazole. 1/3 of the AIDS patients develop the esophageal symptoms, dysphagia and adenophagia. About 50 to 70% due to the candidiasis. Usually treated empirically, endoscopy and biopsy with HPE and the cultures. No response in the 7 to 10 days. Enteric pathogens in southern India, HIV infected patients with and without diarrhea, protozoal pathogens. Most commonly here is Isospora billi and Giardia lamp. So chronic diarrhea is a very, very common in HIV individuals. So these are the common therapies. Cryptosporidia, use the azithromycin. Isospora, cotrimoxazole. Cyclospora, cotrimoxazole. Giardiasis, metronidazole. So in bacteria, long-standing, so you can use the quinolines like your ciprofloxacin or ofloxacin. And strongyloids, thiabendazole. So these are all the gastrointestinal involvement of chronic diarrhea in AIDS individuals and the different antibiotics we use it depending on these organisms. Hepatobiliary system, so there will be the hepatitis, maybe the drug induced because of your heart therapy. Nevirapine and indinavir, they cause the drug induced hepatitis. And most of these people are alcoholics, so ethanol use, so there will be the alcoholic hepatitis. And there will be combined hepatitis B virus and C virus, especially in the drug abusers. Acalculus cholecystitis and cholangitis, like cytomegalovirus, cryptosporidium, microsporidium, and pancreatitis, maybe the drug-induced NRDS and pentamidine. So these are all the systems involved. So the gastrointestinal system from top to the bottom, and also the hepatobiliary system. So the liver, the gallbladder, and the pancreas can be involved in AIDS. The genitourinary, there will be the HIV-associated nephropathy, that is the focal segmental glomerulosclerosis, FSGS. So very, very aggressive disease, and a lot of these people, they need the dialysis services and also the transplantation. So the proteinuria, edema, and hypertension, this is a very common in nephrotic syndromes. Ultrasound enlarged in the early stages, and later it is a contracted. Renal biopsy, FSGS is 80%. There is a focal segmental glomerulosclerosis. So very, very aggressive and dangerous one. And mesangial proliferation 10%. So if the person gets the minimal change glomerular nephritis, luckiest population. So because the treatment is very very, very responsive to your steroids. So steroid response is very good in minimal change glomerulonephritis. But in HIV and AIDS, you have the FSGS, which is very, very dangerous and very, very aggressive. So treatment here, use the ACE inhibitors, steroids depending on the response. And if you want to use the steroids, so use the prednisolone 1 milligram per kg body weight. Not always 60 milligrams per day, sometimes 80 milligrams, 100 milligrams, or maybe the 40 milligrams or 30 milligrams. And you can gradually have to taper the dose here. And you all know the disadvantages and the side effects of the high prednisolone therapy. So Cushingoid features. Drugs that causes the genitourinary side effects, the pentamidine, amphotericin, cidofovir, tenofovir, trimethoprim sulfamethoxazole combination, and indinavir associated renal calculi. So genitourinary tract infections. So like very common, earlier I told you urinary tract infections of all organisms, plus some viral, candidiasis, fungal, syphilis. So they are also very common. So this is something about your genitourinary infection. On one hand, you have the infections, not only the simple organisms, but with the very complicated organisms. And also there will be the FSGS, and which is very aggressive and dangerous one. Coming to the endocrine system and the metabolic disorders, lipodystrophy, and you have the thyroid abnormalities, and you have hyponatremia, and you have the adrenal abnormalities. So these are the common endocrine abnormalities you see in the HIV. Lipodystrophy, the elevation is the plasma triglycerides, total cholesterol, apolipoprotein B, hyperinsulinemia, and hyperglycemia. So more insulin resistance. So these are all the lipodystrophy. So dyslipidemia is very, very common in HIV individuals. Not only because of the HIV AIDS, maybe because of your drug-induced abnormals in the lipids of your heart therapy. In thyroid, subclinical hypothyroidism and hyperthyroidism, here the TSH will be elevated, but not the T3 and the T4. T3 and T4 are the normal. TSH is elevated, that is subclinical hypothyroidism. T3, T4 normal, but the TSH is very low, so that is your hyperthyroidism. Immune reconstitution Graves' disease, some infections in the thyroid caused by these organisms, and then the hyponatremia, syndrome of inappropriate ADH, adrenal mycobacterial infections. So the tuberculosis infection of the adrenal gland is very common. Cytomegalovirus, cryptococcal disease, histoplasmosis, or ketoconazole toxicity. Hypogonadism in the men is very common in HIV positive individuals. So low sperm counts. So this is the lipodystrophy. This is the very important one. Immune reconstitution inflammatory syndrome. IRIS. Okay. So the following the initiation of the ARV therapy in patients CD4 counts less than the 50 cells. Similar to the type 4 hypersensitivity reactions, frequently seen in the setting of the tuberculosis. Clinical features appear 2 weeks to 2 years after initiation of the heart therapy. There will be the paradoxical worsening of the pre-existing, untreated or partially treated opportunistic infections. Localized lymphadenitis, prolonged fever, pulmonary infiltrates, increased ICT, uveitis, and Graves' disease. Clinical course can be protracted and severe cases can be fatal also. So this is the IRIS. IRIS is a short notes for you. This is the hemopoietic system, lymphadenopathy, anemia, leukopenia, thrombocytopenia. So almost like a pancytopenia. Picture like can be seen here. On one hand, you have the anemia, maybe the RBC count may be the low, leukopenia, WC count will be low, thrombocytopenia. So that is a pancytopenia mostly. Bone marrow suppression by HIV infections, mycobacterial infections, fungal infections, lymphomas, maybe medications which suppresses the bone marrow, your heart therapies, zidovudine, dapsone, etc. Persistent generalized lymphadenopathy, idiopathic thrombocytopenia purpura, ITP, deep vein thrombosis or pulmonary embolism, pulmonary hypertension. So these are all the diseases of your hemopoietic system. Dermatology, seborrheic dermatitis, folliculitis, psoriasis, ichthyosis, reactivation of the herpes zoster, herpes simplex virus, molluscum contagiosum, Condylomata acuminatum, extrapulmonary pneumocytosis, some drug reactions like erythroderma and Stevens-Johnson syndrome. This is all because of the sulfur drugs. You know that. Not only sulfur drugs, some ART therapy, especially for NNRTS, they also cause these drug reactions. So these dermatological manifestations are also very, very common in our HIV individuals. Neurological diseases. So it's very common as far as the physician's point of view. So the toxoplasmosis, cryptococcosis, cytomegalovirus, syphilis, tuberculosis. This is a very common neurological diseases here. Not only that, neoplasms like lymphomas, CNS lymphomas, Kaposi sarcomas, myelopathies, ataxias, paresthesias, peripheral neuropathies like acute Guillain-Barré syndrome or mononeuritis multiplex, polyneuropathies, myopathies, or cranial neuropathies. So these are all very common in neurological disease. So you name any disease that is very common in AIDS, especially the neurology is concerned. Cryptococcal meningitis, subacute meningoencephalitis. Average duration of the symptoms 30 days. Clinical manifestations like any other meningitis, you have the headache, fever, neck stiffness, some seizures. CD4 count is very, very low here. Predictors of the poor outcome, a prolonged coma, high opening pressures, WBC is very, very low. Cryptococci isolated from the extraneural sites. And diagnosis confirmed as CSF examination with India ink preparation. So that's a very, very important in cryptococcal meningitis. But don't use the steroids here in cryptococcal meningitis. So steroids are contraindicated in cryptococcal meningitis. So you can use the amphotericin B, or you can use the fluconazole, and you can use the sulfamethoxazole pyrimethamine combination, etc. So this is the cryptococcus. So induction here, the amphotericin B and the flucytosine, maintenance with the fluconazole, and repeated the lumbar punctures for elevated ICP. Steroid treatment associated with the treatment failure and the death, hence not recommended. So don't use the steroids in cryptococcal meningitis. See here, this is the toxoplasma, mass-like lesions. They present with the convulsions also. So the focal neurological defects, seizures, fever, generalized cerebral dysfunctions like confusion and coma, some neuropsychiatric manifestations, multiple ring enhancing lesions located in the frontal, parietal lobes under the basal ganglia, corticomedullary junctions. Here the serum toxoplasma IgG usually the positive in 97% of the cases. Treatment, use the pyrimethamine, clindamycin, azithromycin, clarithromycin, or trimethoprim sulfamethoxazole combination. So steroids for cerebral edema and the mass effect. Here the steroids are needed, useful, whereas in cryptococcal meningitis they are the contraindicated. Here you have to use the steroids to reduce the cerebral edema, to reduce the mass effect, and also to avoid the convulsions. So this is the cytomegalovirus retinitis, again in the HIV positivity AIDS population. Here the CD4 count is also very, very low, maybe less than the 550. Here you use the genciclovir or valganciclovir. Both are in the BD forms of the body for 2 to 3 weeks. This is again another important thing in the HIV positivity. Progressive multifocal leukoencephalopathy. PML. So this is the JC virus, multifocal demyelination, relatively rapidly progressive neurological syndrome over the weeks or the months. Cognitive dysfunction is the very, very common here. Not only the cognitive dysfunction, these people will have the ataxia, aphasia, cranial nerve deficits, hemiparesis, quadriparesis, or finally coma. CT, singular multiple hypotenuse, non-enhancing cerebral white matter lesions. See here the white matter lesions. So this is the typical picture in your progressive multifocal leukoencephalopathies. Malignancies are very common, as I told you earlier. So the Kaposi sarcoma, even though we say Kaposi sarcoma is very common, and luckily it is not that common in Indian population. So the Indian population, the most common neoplasms in our AIDS patients are the lymphomas and invasive cervical carcinomas. Kaposi sarcoma is the multicentric neoplasm, multiple vascular nodules appearing in the skin, mucous membranes and viscera. Extensive disease, you have the initial therapy with interferons, subsequent therapy with the doxorubicin, a combination chemotherapy with the low dose doxorubicin, bleomycin and vinblastine. So the ABV and radiation. So they are all the treatments of the choice in your Kaposi sarcomas and lymphomas. What are the testing options for the HIV? See, already I told you this ELISA, Western blot, rapid antibody test, absolute CD4 count, and viral load. So these are very important. When you are first, you will get the rapid antibody test. When you are in doubt, get the Western blot. When the fellow is in the window period, get the ELISA or the RT-PCR. And once it is confirmed that the patient is HIV positive, you want to start the ART therapies. So then CD4 count and the viral load. So these 5 are the very important investigations to be done in all the HIV positive individuals. Urine testing in some, oral testing in some, diagnosis already told you. So this is the genomic study. Laboratory monitoring, you will get the CD4 count done once in every 3 to 6 months. Hypersplenism, or who have undergone the splenectomy, you have the CD4 T cell percentage. RNA determination, HNA, RNA, viral load at the time of the diagnosis, and every 3 to 6 months untreated patients. And monitor every 3 to 4 months effectiveness of your therapy. Once the patient is on ART, so again you have to get the CD4 count and HIV viral load, that is your RNA. Okay, to know the effectiveness of the drugs. So the treatment options, you have the several drugs right now in our hand. We have the fusion inhibitors, nucleoside reverse transcriptase inhibitors, and non-nucleoside reverse transcriptase inhibitors, NRTS and NNRTS, and then the protease inhibitors. So the protease inhibitors, fusion inhibitors, and NRTS and NNRTS. These 4 are the very important group of the drugs to be used in heart therapy. So the nucleoside reverse transcriptase inhibitors, the classical example is the judovidine, and non-nucleoside reverse transcriptase inhibitors, nevirapine, and protease inhibitors is the ritonavir. And essential lab tests, so not only your CD4 count and viral load, so get the tests done like CBP or liver function tests or renal function tests, your electrolytes, lipid profile, thyroid, uric acid, okay, blood cultures, urine cultures, so etc. So there are very important investigations to be done in all the positive population whom you want to start the heart therapy. And infections are very common in these individuals. Initiation of the ART, what are the indications? So the acute infection syndrome, the chronic infections may be the symptomatic or asymptomatic. Even in the asymptomatic, when the counts are very low, so you have to start giving that treatment. In pregnancy, whether the symptomatic or asymptomatic, all the pregnant HIV positive individuals, so she would be treated with the ART not to get the transmission of the disease to the fetus. And post-exposure prophylaxis or sometimes pre-exposure prophylaxis. So this is the where the different places where the drugs will act. See the HIV particles, drugs under the study would block the binding. Some existing drugs inhibit the reverse transcriptase. Drugs under study would inhibit the integrase. Okay, protease, some drugs which inhibit the proteases. So the protease inhibitors, integrase inhibitors, so reverse transcriptase nucleoside inhibitors, etc. So there are the different drugs available right now to treat these drugs. So these are the different drugs like nucleoside analogs, zidovudine, diadenosine, jaltiseptavir, abacavir, stuvadine, lamivudine, emicetrapine, and tenofovir. Non-nucleoside reverse transcriptase inhibitors, delavirdine, nevirapine, efavirenz, and etravine. Integrase inhibitors, raltegravir. Protease inhibitors, ritonavir, nelfinavir, lopinavir, saquinavir, indinavir. So these are the different drugs. Entry inhibitors, you have the Mavorixafor. So some side effects of these drugs are there, especially the lactic acidosis and hepatic steatosis, or the fatty liver, or lipodystrophy, all NRTs. So nucleotide reverse transcriptase inhibitors, they cause the liver and the fat side effects like fatty liver and lipodystrophy and lactic acidosis. Abacavir, it causes hypersensitivity reaction. Adenosine, gastrointestinal intolerance and pancreatitis. Stavudine, nowadays we are not using the stavudine. Peripheral neuropathy and pancreatitis. Tenofovir is very commonly used drug that causes the headache, GI intolerance and renal impairment. Zidovudine, earlier we used zidovudine extensively, causes the headache, GI intolerance, bone marrow suppression. In pregnant women, increased risk for the lactic acidosis and liver damage when treated with the stavudine plus diadenosine. So this is the monotherapies, true drug therapies, and the combination therapies. So now you agree with me that the combination therapy is the most useful drugs in nowadays. No, the single drug or the two drugs. Minimum the three drugs you have to use it right now. So these are all the hot regimens. 2 NRTs plus 1 non-nucleoside reverse transcriptase inhibitors. 2 NRTs plus 1 protease inhibitor. 3 NRTs only in the special situations. So mostly we use either 1 and the 2. So the 2 NRTs plus 1 NNRTI or 2 NRTs plus 1 protease inhibitor. So what are the indications for changing the ART? The CD4 count should increase at 6 months. So you started the therapy when the CD4 count is at 200 or 400 or 300. And after 3 months or 6 months, you are getting the CD4 count again. So the rise of the CD4 count should be there to say that the drugs are very effective. Otherwise, once the CD4 count is coming down in spite of the usage of your heart therapy, that means you have to change the ART because this particular ART is not helping that individual in not decreasing the count and reducing the not increasing the count and also reducing the viral load. So find primary prevention, 5 ways to protect yourself. Most important thing is abstinence, monogamous relationship, so with only one person, protected sex, sterile needles, new shaving and the cutting blades has to be used very effectively. So abstinence is very, very important. Refraining from unprotected sex, oral, anal or vaginal. Refraining from the intravenous drug uses. Monogamous relationship, only one sex partner. Condom usage is very, very important. Prevention of the HIV transmission, the personal strategies and the public health strategies. So safe practices, risk reduction, these are all very important. Prevention of HIV transmission, public health strategies to prevent the HIV transmission. So what all the NGOs they do that. So a lot of NGOs, so they concentrate more on these public health strategies to prevent it. So they screen all blood and blood products, follow the universal precautions, educate in the safer sex practices, identify and treat the sexually transmitted infections and other infections, provide referral for treatment of drug dependence, apply the comprehensive PPTCT approach to prevent the vertical transmission of the HIV. So this already I told you. Direct infection of the organ systems can directly infect the brain. So HIV dementia can involve the gut. So HIV wasting can involve the myocardium, cardiomyopathies. So these are all very commonly infecting the organs. So HIV multiplies inside the CD4 cells, destroying them. Without ARV treatment, HIV progresses the symptomatic disease and HIV. That is the reason we are starting the heart therapy, antiretroviral therapy. So December 1st is the World AIDS Day. So know your HIV status, your friend status. The goal of the treatment, the main goal of the treatment is to keep the person's immune system functioning as close to the normal as possible. That is the goal of our treating the heart therapy. So immune system as normal as possible. So this must keep the person's viral load, the number of the virus particles circulating the body as low as possible, not detectable. Keep the person's T cell count as high as possible, more than 800,000. So combination therapy to reduce the viral load in the blood. Some drawbacks, complicated dosage schedules, cost, side effects. Living with HIV. So now we consider the PLWH. So the people living with HIV is the international nomenclature for the HIV positive individuals. Eating right, exercise, plenty of the sleep are especially important for people who are HIV positive. Even HIV positive, non-HIV positive. So all the people eating, exercising, and then the sleep. So they are very important. Regular visits to the doctor is very important. When they are healthy, HIV positive people can carry on with their careers and other activities. Support from the personal support, friends support, family support. These are all very important. Treat all fast. Reduce the time in which a person with HIV can get an HIV associated condition. So all these diseases would make you delay when you delay the ART, so some of these people can get the cryptococcal meningitis, Kaposi sarcomas, undetectable viral load, CD4 count more than 700, etc. In Asia and the Pacific, 4 in 5 children living with HIV are receiving the life-saving ART, thanks to the NGOs. Late diagnosis in Asia and Pacific, a cause for concern. Even see the India, so 41%. So the diagnosis with the CD4 is less than 200, 41%. CD4 between 200 to 350, about 35%. CD4 more than the 350, 24%. So roughly 75% people in India, so when they get the tested the CD4, it is less than 350, less than the 350. So HIV treatment can prevent the sexual transmission. So these are all the approved drugs. So the first drug entered into the market is the judovidin, and the latter lot of the dinosine, stevidin, lamivudin, etc. So to the recent drugs like Trivasi, cabotegravir, lenacapavir, riponavir. So these are the different drugs that are available. So HIV treatment has come a long way. With the daily medication, most people with HIV can live a normal lifespan. But unmet needs still remain. Some people find it hard to remember to take their medicine every day, maybe because of their HIV dementia or encephalopathy. So others develop drug-resistant strains of HIV that make the medications ineffective. Here in HIV also, there is a drug resistance. So fortunately, the researchers continue to search for the new and better HIV treatments that can fill these gaps in here. Here is a look at some of the most exciting options. So the promising drugs in the development. See, in 2021, FDA has approved Cabenuva. It contains 2 drugs. One is cabotegravir and rilpivirine. So this is an injection once a month or once every 2 months. So either once a month or once in 2 months. You can take this injection. So this injection is called as Cabenuva. This is a combination of cabotegravir and rilpivirine. See how beautiful it is. Just once a month or once in 2 months, if they take an injection, so that will take care of the viral load and they improve the CD4 count. And then again in the 2022, FDA approved lenacapavir, Sunlensa. It is the second injectable HIV medication. The first one I told you, Cabenuva, injectable one. It is the second injectable in a new class of the drugs called capsid inhibitors, meaning that it affects the cell that protects the virus, preventing it from multiplying. So just like a capsid inhibitor, so that is also available right now. And again, a drug that is close to getting the FDA approval is the islatravir. So that is another drug. It is called NRTTase, that is nucleoside reverse transcriptase inhibitor. So these are all the upcoming drugs available, approved already by FDA in 2022, injectable once in a month or once in 2 months. Now the vaccines. See, the researchers are developing a therapeutic HIV vaccine. Therapeutic vaccines treat a condition rather than prevent it. People who already have HIV would get this therapeutic vaccine to help them strengthen their immune system's response to the virus. So the hope is that the vaccine alone would prevent HIV from progressing to the AIDS without the need for the ART. So once they give this therapeutic vaccine, so they improve their CD4 count, so they improve their immune system, so that the HIV people will not enter into a stage of AIDS to get the opportunistic infections and the malignancies. So that is the advantage of this HIV therapeutic vaccine. Then the gene editing, so that is also there. So this is the life cycle. So there are all the targets for the HIV medications. See the picture here. Before the HIV infection, see the CD4 cells in the first one. So once the HIV virus is entered into the blood, slowly the CD4 cell counts are coming down, and you see the last one. So total blood vessel is filled with viruses only, no CD4 counts. So the post-exposure status, the different regimens are there, some side effects. So these are the drugs for post-exposure. Just take these tablets: Truvada, tenofovir, emicovir, and emicetrapine, indicated for all with high risk of HIV infection. So the universal precautions are wearing gloves, wearing gowns, wearing masks, disposing of the syringes and the needles properly. So they are all the universal precautions. Vaccines already I told you. So thank you very much for your patient hearing.